Dear colleagues and friends, my name is Belograd, and we start our YouTube video series that are dedicated to clinical cases review. I would like to say that the idea to create these video episodes on our YouTube channel was because of our previous webinar about aesthetic treatment planning. And that webinar, I can tell you, was super powerful regarding content and time, and literally it was so much information that we were not able to complete this webinar completely because of the time restrictions due to live broadcasts. So we decided to record few additive cases that were complemented to the topic of this webinar, and to send to our participants, to everybody who attended our online masterclass, our webinar. And then suddenly the idea came, why don't we provide that type of educational videos for the regular basis on our YouTube channel and share this for free for everybody. So I can say that now we start series of that video cases review on our YouTube channel. So if you still are not our subscribers, subscribe to our YouTube channel, because there will be a lot of useful content and information that we will be happy to share with you. So let's go. This case that I'm going to share right now is a case that we call copy-paste. This case is about aesthetic rehabilitation. This case is about consultation, and this case is about communication with patient. The main concern, the main complaint of patient that when she came to our clinic was a smile. Let's say she wanted to improve her smile. She was not happy with the length of teeth, and she was not happy slightly with the color of teeth. As we can see here from the facial photos, especially if you will analyze the first picture here, you may see that there is not enough display of frontal teeth through the upper lip, which gives you an idea that central incisors are slightly short. And basically she wanted to make her central incisors longer. So during first consultation, we collected all patient complaints. We discuss with patient what actually she wants, and also me as the clinician, I collected enough information and enough data about the conditions of her teeth and her system, let's say, in order to compose treatment planning. If you may see here, if we will go a little bit closer into the intraoral picture, what we can see that the teeth are really short. They're almost one line here. Central incisors are built up from direct composite restoration. We do also have some composite fillings on lateral incisors. You can see abraded canines, and you can see some signs of erosive obstruction, which means there is some occlusal overload for her teeth. It is proved also by evaluating of even these intraoral pictures of upper and lower jaw, that you can see that there is no anatomical restorations. Almost all occlusal surface are flat, and this is not just aesthetic case. This is case where we need to restore all system. Especially when you need to make teeth longer from the anterior area, you understand that you are interfering into the envelope of function. So basically we discussed with patient aesthetic outcome, and also we discussed with patient that to get this aesthetic nice result, long-term result, we have to redesign all occlusal surfaces of posterior teeth. Otherwise, if we will just do frontal zones, frontal incisors, make them longer, make them more beautiful, the result will be short-term. She may break them, or she may abrade these teeth. So we decided to go for full mouth rehabilitation. And the problem was that during this consultation, that period of time, she was not able to complete this treatment because of financial issues. So ceramic restorations that were offered as the first option from my side were rejected because of the economical issues, as I mentioned. So we decided to offer to this patient alternative, let's say, option, alternative solution. And we decided to do so-called copy-paste technique as more economical driven, but treatment planning of copy-paste technique is absolutely based on common principle of full mouth rehabilitation cases. In this case, I followed principle which is called facial engineered treatment planning. So aesthetic treatment planning, let's say, a part of treatment planning was taken as the base for occlusal rehabilitation. In other words, we used golden proportions, we used templates to understand exact length for central incisors from aesthetic point of view. By the way, when we use these templates, when we have these golden proportions and templates to understand exact length of central incisors, nowadays become really simple. Because just imagine if you don't have any templates, if you don't have any guides, it's pretty difficult to understand to make this longer for 1 millimeter or 1.5 millimeter or maybe 2 or 3, etc. But now we can do everything just analyzing picture, just within a few minutes, and we will get a guideline for ourselves and for our dental technician to follow other steps to complete aesthetic and functional, in this case, rehabilitation. So when you understand the length of central incisor, when your dental technician will also understand the length of central incisor, we can build up occlusion when we mount modules into the articulator, when we mount the lower jaw, we made a proper overbite, and then we go into occlusal rehabilitation because we'll have some space, but this is another topic, not about this, just about this case. So aesthetic component was based on smile design. We made also digital prototype within first consultation to show to our patient and also to ourselves to understand if that kind of design will be okay for patient or not. Before I will go into the next slides, I would like also to point your attention that this digital proposal is like a sketch, is like initial thing, is like it's like not like a base even, it's just initial idea regarding aesthetic outcome. But this one, I mean contours and measurements, will be taken as the base for dental technician when he will be doing wax up. I mean geometry, length and width will be taken as the base for wax up. This digital thing that you can see here and here is just motivational part of consultation to show to our patient slightly initially how they will look like with the changed smile. Let's go back to intraoral pictures because we would like also to show you some interesting aspects of her lower teeth. You can see that lower teeth are abraded, and also from cervical areas you can see patterns of overload. So again, we have to do in this case occlusal rehabilitation because otherwise we may fail the case. During first consultation we deprogrammed our patient, we registered CR, in this case we used leaf gauge, and then we transferred this information to dental technician. Our dental technician took all the data that we gave him and he made wax up in articulator, in CR, driven by our aesthetic proportions for central incisors. I didn't mention that this case is pretty old one. We made this case in 2013. So that time we were working in analog, so everything was done by hands actually. So the second step was to transfer wax up into the patient's mouth. This is the thing that we have to do for this copy-paste technique. Copy-paste technique, I would like also to mention that copy-paste technique is a nickname of procedure. The original name of that procedure is transitional bonding. I think the author of transitional bonding technique is Buddy Mopper, and he cooperated with prosthodontists, and they made full mouth reconstructions in case when patient again didn't have enough, let's say, money to afford expensive treatments. So as option was offered to do composite restorations, composite build-ups driven by wax up, And then these composite buildups were transferred into ceramic restorations later on. That's why it is called transitional bonding. In our case, we decided to do this transitional bonding technique as final restoration, utilizing normal, packable, restorative composite material. So we took impressions from the wax-up using transparent silicone index. Nowadays you may find different brands of transparent silicone index. You can find from GC, you can find from Ivoclar, you can find from Micherium, you can find from Germag. So basically there are a lot of different types of transparent silicone that you can utilize in your regular daily basis. One tip: if you will just take impression with transparent silicone index, it will be pretty soft, and if you will press and manipulate with this transparent silicone index in patient's mouth, you may get distortion because material again is pretty soft. The trick is to perform the pretty rigid base. The rigid base can be created by using of thermoplastic material, the same material actually that we are using for night guards or for bleaching trays. Dental technician makes this base, let's say, made of 2 millimeter vacuum formed thermoplastic material, which is pretty rigid, and then we have to reline this material with a transparent silicone. To reline this base with transparent silicone, we can use pretty simple steps. We take this base, we take this vacuum formed tray, let's say, or guide, let's say. We do sandblasting, or dental technician actually does internal sandblasting with aluminum oxide. Then you take special adhesive that we're using for customized trays, okay, for silicone, for taking silicone impressions. You take this adhesive for silicone impressions, and then you inject your transparent silicone inside this tray, and also some silicone may be injected into the wax-up, and then you take impression with this tray. So literally you will reline this tray and you will get a nice reflection of anatomy and texture from the wax-up. This is the trick. So let me show you how it works in posterior areas. So this is the fragment of posterior teeth. The good thing from this technique is that it is absolutely non-invasive. If you have teeth with no caries, with no fillings, with nothing, just abraded or treated, you just do bonding protocol. You etch, you rinse, you bond, and then you put your composite, then you take your silicone index, you press, you light cure, and you get this copy-paste actually this result. The only thing that you have to be really careful is excess of material that can that can be pressed into interdental spaces. Okay, so if you need to add a little bit of amount, it's easy. But if you need to add a little bit more, you may do few tricks. You can do restorations one after one. I mean, one after one, and adjacent teeth will be covered with a Teflon tape, for example. Or you can make some customized matrix systems to put them in between teeth. But still, you may have excess, and you will spend some time removing this excess from interdental spaces. You can do individual, customized single tooth stamps, which will be more accurate, and you will restore one by one, let's say, and remove some excess. Or you can do semi-direct restorations for that type of technique. So there are a lot of ideas how can you implement copy-paste technique in your daily basis. Can be direct, can be indirect, and can be semi-direct techniques using composite materials. These techniques, by the way, we covered during our hands-on courses during Module 2, so if you're really interested in that type of dentistry, I would like to invite you to attend our Module 2 course. On our webpage, you may see the link in description of this video, so you can see the link down side of this video. Okay, let me show you something from frontal area. I just removed old composite from frontal teeth. I also removed secondary caries, and this is the way we restored palatal areas, palatal sides. We did it one after one, as I mentioned. Adjacent teeth were closed with Teflon, then we made sandblasting, then we do etching, then we do bonding, then we place composite, make adaptation, press, light cure, and then you will have a lot of fun taking this composite from interdental embrasures and interdental spaces. So it is not that easy. It is possible, but you will have to spend some time taking this out. So this is one of the options to use this copy-paste technique. Frontal teeth, I mean buccal surface of central and lateral incisors and in canines as well, were restored by freehand technique. Nowadays we can also use copy-paste to restore buccal surface, so you can copy nice texture from the wax-up and you do just copy-paste directly. At this moment in 2013, actually I didn't know that we can do it in easy way, and that's why I decided to do freehand. But anyways, we got that result, we restored teeth and we made some finishing and polishing procedures. We created texture. You can see how these palatal sides look like after copy-paste technique, which is really nice. Before and after, upper and lower teeth, frontal zones with texture and relief, upper jaw, the new smile. Especially you can take a look at these ones. This is the one that I really like. I mean these lips in rest or picture in rest, when you can see now display, which is really good. Okay, and we have 3 years later result. So this is 3 years later. This picture was taken before hygiene, before repolishing. So you can see some slight discoloration between teeth, which is really easy to be solved by just repolishing procedure. And you cannot see now texture or relief, no perichematas, because even during normal regular toothbrushing, dental hygiene, you may lose this texture after some period of time. But what is really good from this technique is that, as I mentioned, it is minimally invasive, it is more or less predictable, it is feasible because you can, if you will make any mistake, you can remove this composite in easy way and redo. You can make some adjustments, you can make some corrections, okay, and you can do that type of treatment in a really short run. So I can tell you that all process of treatment took me 3 days after I got wax up. So during 1 day I restored posterior teeth of upper jaw, and then I restored lower jaw, then I restored frontal teeth, made some occlusal adjustments, polishing, and the case was actually finished. After 3 years, everything is pretty acceptable, aesthetic acceptable from patient point of view, but also from dental point of view, it's not bad, it's okay. Occlusion is stable. The only problem that we have here is that still we don't have lower molar. She promised us that she will put implant, and also when we were planning the case, we evaluated that this one has to be extracted and replaced by implant. But still, you can see after 3 years, the tooth is in the patient's mouth, and patient used this tooth, and etc., etc. So it works. Anyways, I cannot force my patient to extract. This is her decision. Anyways, this is the result you can see from frontal area from 2013, before, after, and after 3 years. Pretty good result, as I mentioned, as well as the lower jaw, and some summary about this case. So this case was driven by aesthetic treatment planning, and then aesthetic treatment planning was transferred into occlusal treatment planning. So aesthetic parameters were used as the core base to restore occlusion. We understood, we designed, we evaluated the length of central incisors utilizing templates, golden proportions. So we did some digital smile design first. Then we transferred this information to dental technician. In this case, we decided to go into deprogramming. We defined CR that time, Then we got wax up, and then we transferred wax up by use of transparent silicone indexes with a copy-paste technique, utilizing normal packable restorative material. This patient was not able to afford treatment with ceramic restorations because ceramic restorations actually were offered her as the option number one, and since some economical issues, we offered her that option. And you can see after 3 years everything is all right. Now it's 2019 and still everything is good. Patient is happy. She doesn't want to change anything. So basically I can say that everything works with composite if composite restoration driven with a nice and proper treatment plan and the performance of this treatment plan. Okay guys, so I think that we're going to finish this clinical case review. I would like to ask your opinion regarding this format. If you like this format, please send us some comments under this video. If you want us to make case review of another clinical situation, which one? Please again text in the comments. Say us which kind of clinical situation you want us to record to make this kind of review. If you want to participate in webinar, because of this webinar we actually started this series, you can also see the link below this video, and we will keep going, we will keep running with that format. So again, if you still are not subscribers, subscribe to our YouTube channel, use this bell here to switch on notification, because there will be a lot of new information and content, and we don't want you to miss this content. Okay, so that's it. I wish you good luck. I wish you a lot of power and good health to realize all of your ideas. My name is Maxim Belograd, and I will see you very soon here in YouTube channel. Bye bye.